Shelley, you said the assessments have started. Have all the, I know we haven't received our list. Have the lists been sent out to providers so that we can review them? And where are you at as far as really starting? I know we did some preliminaries in October.
And I know that Pine Bluff did some initial contacts with some providers. As we developed issues with the electronic system, especially in what we called, like remote or disconnected, so they could be at a person's home way out in the country, no Wi-Fi. We were having specific problems there, and we never knew when we might encounter that situation. They have tried over the last few weeks to concentrate at the Human Development Centers, knowing that everybody had a good environment for connectivity. And so, but we asked them to stop that time of concentrating there at the end of November. So I imagine it would be very soon that they would begin to reach out and talk with community providers to say, who can we see and when? So if you have any questions, Pine Bluff Psychological Associates, I don't have their number here with me today. You can always email or call me, and they're good to get back with you. So just give Pam or Ken a call, and they'll talk with you about how soon they plan to start getting out in the field.
When do you expect for us to have discussion with regards to community first choice and institutional level of care for us to, develop? Because, you've got long-term care that actually determines the institutional level of care for those that are admitted into our HDCs and into our ICFMRs. And then, of course, we have DDS that makes that determination for waiver. And do you anticipate us having the need under CFCO to develop a standardized definition criteria for institutional level of care, or will that be based on the results of the assessment and the level of care as assigned per the assessment?
Let me see if I can answer this without, the answer is yes. Let me qualify it. I think that we have to have the assessments in hand before we can sit down and do that. We do need to have a discussion between now and then about the framework. I know that Shelley has been meeting with Aging and Adult Services and long-term care to talk about how we're going to do this in the future. As Shelley said, we're going to bring several thousand people into the service system pretty quickly, and that means a bunch more will show up going, well, wait, I didn't realize there wasn't a waiting list. So we're going to have the framework of how that's going to happen and who's going to do the income eligibility, who's going to draw, how are we going to draw that line that two people draw now, like as Craig pointed out. So we've got a little time, but it's also something we don't want to wait too long because of the infrastructure needs at the department. Because we know that our friends over in the county operations who do regular Medicaid applications and do thousands and thousands of them every hour for that matter, they are also having to undergo a change with the ACA and a possible expansion and the insurance exchange that's coming whether anybody likes it or not. So they are undergoing a huge culture change over there, and that's a place where if they get one day behind, that's huge. So long-term care has always been an outlier. We have different criteria to get in. A lot of times the income eligibility is different. It is for us. It's 300% as opposed to 100. So when they drew up the flow chart for eligibility and determination, and they had a lot of automated boxes where a computer was going to be able to say, yes, no, go this direction. They had one box coming off the bottom that said long-term care. And that's us and Aging and Adult Services. So that's why Shelley's been getting to talk with them. Y'all, I think it's one of those things you're just going to have to keep asking, because we certainly don't want to get up into November and go, oh, yeah, we forgot about that, and have this huge influx of people that are all banging on Shelley's door wanting to, hey, tell me if I'm institutional level of care.
Then I've got one more.
Right.
Here on the slide on page 7, it says waiver and DDTCS services to be replaced by CFCO offerings. The income eligibility requirement for waiver is different than that from CFCO. So do we anticipate that changing, or do we, I know we had talked about keeping, that waiver open for those that did not.
Yeah, I was looking to see in an earlier version of this that we did have that called out. Don't see it in here. Anna, who should stand up and wave at this point. So now, see, she already doesn't do what I say. She's been working for 2 months. She's kind of, hell, I'll wave, and I'm not standing up. Anna's heading up the CFCO application for the whole department, and she has been conversing back and forth with CMS and other states, and to retain that 300% threshold, and we may be getting off in the weeds too much for some of y'all, but this is a very important point. On the waiver and in an institution, and even a 10-bed institution, right now, you can have up to 300% of poverty. Is that right? It's 300% of SSI. I'm sorry. And most of our guys, that's not an issue. If you cut it to 100%, then people who have railroad pensions that have been left or SSA, it's easy to get over 100, not as easy to get over 300, so we have to keep that in. Coincidentally, waiver case management, which we are going to try to convert into a health home, cannot be a CFC service. So it naturally fit into keeping as a waiver. Now, to retain the 300% threshold, all you have to have is one service. And, of course, we want it to be a service that everybody gets. Everybody on the institutional level of care needs that service. So case management / health home is that service. So everybody would get that. They'd get it under a waiver. We'd have no need for an elaborate waiver staff, waiver processes, because you're only going to get one service, and it's case management for the health home. I got to start calling it health home. So we would be able to keep that eligibility issue from becoming a hardship and make sure we had a place for our health home to fit in, even though we're not going to get the 6-point break on it. We're still got a pretty good match rate at 30%. It take me a long time to describe the co-ops. We feel like that's an integral part of crisis intervention in Arkansas, something that we haven't had before. It helps us both in keeping someone who's having an acute mental health episode from having to move to an HDC when that might not be the best setting for them. It helps us allow people to stay in their homes in some cases and not risk being out because they missed a month of rent, not risk having their provider have to go find other jobs because they've been up at Conway for 6 weeks. We retain that level of care at the HDCs because there are some folks who that's where they'll end up needing to be. That's where they'll want to be. They may want to stay. They may want to come back out. But we got to have every step in that continuum, and we do not have good community-based crisis intervention. That's why I put it in a budget request. I think that's why the governor included it in his budget, and I'm hoping that's how the General Assembly will see it, so that we can partner with our provider associations to help keep those people where they want to be. One more question, and we got to move on.
This question is for Shelley.
All right, I'm glad.
Correct me if I'm wrong here. I may have misheard you, but are you saying that we've sent out assessors into the field without mobile hotspots? Are they entirely dependent on the wireless network of the provider?
No. In fact, that was what the issue was with this disconnected. There's an effort. It was a way for them to check out a member record in the MedCompass system. The folks that we serve are called members. Check out a member record, work on that, and then when they get back into a wired environment, an environment where the internet is possible, then they could check it back in. But truly, when you go into a person's home on the end of a dirt road, you're not going to find anything in many cases. And so there was an effort that is the most complicated part of it, just to be sure that we have that available. Segmenting clients into levels based on assessment. How we understand that this works is after we have completed 3/4 of the assessments, but as we say in the country, a goodly number of assessments, University of Michigan will download that information and be able to start examining the various characteristics that make up the people that Arkansas serves. And when they finish that process, when they have all the assessments in, I don't say that every single one of the 4,500 plus all significant change reassessments have to be in, but they have to have most of them for fear that there's an outlier or two out there somewhere with a really different set of needs that won't be captured if they're not in there. So anyway, look at all the data, and they'll be able to tell us at that point how many natural different types of service levels there are. We don't know at this point if we'll have 10 or 15 or 20 or 30, but we don't want to artificially push that number down, because it would be easy to say, well, a person who at the end of this is a level 12 and a person who's a level 13 are so similar, let's just mash them into one. But they may have enough characteristics that are different that you just don't want to do that. So I hope that we're able to keep as many natural service levels as there are. But that's step one. Step two is for, again, University of Michigan. We're going to pay them for this data analysis. We'll go back and get historical cost data on each of those individuals. And since we're starting with people who are already receiving services, it sounds really hard, but it's not all that hard. We have a waiver plan amount. We have cost amounts from the ICFs and HDCs once we pull out things that wouldn't be commensurate in community care, like room and board and doing the lawns and medical care, things that you would pay for outside. They'll be able to hook those back to individual people. So when those two steps are done, we'll not only know how many people, how many levels we have, but we'll know how many people are in each service level, and we'll know the approximate cost of that service level. So we'll know that a 12 is between 20 and 22,000, or somewhere, I hope a small enough range that there's a real difference between that service level and the next one. And that is how that system is supposed to work. I think I covered that. On to the next slide. Now, the goals of the project will be tying a care plan through to that episode amount. You can see on the left, we want to minimize budget risk, assure efficient utilization of services. You can see all the goals on that side, aligned with the client's assessed needs. They're not influenced by competing stakeholder priorities. We know that there are some people who get community services or who are more persuasive, perhaps. They can have a better argument for the services that the person they're representing needs. Others are not as successful. They either don't have a case manager who is as fluent in waiverese, or they don't have a family member to step up for them. Whatever the situation may be, there may be people whose service levels in today's world would be the same and their service costs would be different. We want to promote transparency in the care planning process. We already have that to some degree because Office of Long-Term Care for the ICF side, my staff for the waiver side already go out, pull a sample, take a look at care plans, see if goals are met, talk with people, talk with staff. So we have that transparency, but it's a very paper process. It would be much easier if we already had a chance to look at a care plan and to say, this looks funny, let's be sure and put this person on the sample. That kind of transparency would be very helpful, and would also, and the streamlining the care planning process so that everybody who has interest in this person's plan of care, whether it's their physical therapist, whether it's a psychologist, has a chance to participate. And then the emerging perspectives, these are the ways we're trying to go about meeting those goals. We talked about setting the episode amount based on the assessment score, allowing a single PA, a single prescription for all the various kinds of DD services that a person gets. Streamlining that plan development through a web-based system. We have seen, Charlie's right, we've seen some wonderful systems. It's always two or three things. How will it work? How will it work for external providers? And how much will it cost? And how would it be implemented and when? And we've always got those same questions. A standardized integrated care plan template would be wonderful. I know you know how hard it must be for reviewers to try to go out and figure out how Cindy Mahan does her care plans and then go to Keith's place and try to figure that out. It's a very complicated process, and sometimes my folks may miss something just because they're not familiar with the way that the plans of care are set up. We will do what we've always done. We'll always select a sample of plans for review. We do that. I'm not sure if Medicaid audit does a random sample. I know DMS does it when they do the QA on DDS for our operation of our waiver, and that same thing happens in the other divisions as well. We do not anticipate that we'd have to have approval for plan changes within the episode amount. Currently, as I understand the process, if you want to decide mid-year that you don't need the money you put into environmental modification or something else, you've got to go through a fairly complicated procedure to get that changed. We anticipate that that will be much less burdensome. And we talked about being able to automate certain aspects of the plan of care. If the assessment indicates that 5 problem areas should be addressed in a care plan, it would be lovely to be able to know that those 5 areas had been addressed without needing to thumb through a year's worth of paper.